Welcome to the deep dive, where we pull out the key insights from complex sources just for you. Today, we're jumping into the world of surgery, which it's always changing, always evolving.
It really is. It's quite amazing when you think about how far things have come.
Yeah, the constant push to make procedures less invasive, safer, and get better results for patients. I mean, think about the leap from wide open surgeries to today's, keyhole techniques.
It's a huge difference, a testament to that drive for improvement, always pushing what's possible.
And today, specifically, we're focusing on a really cutting-edge area in treating gastric cancer. We're drawing our insights mainly from a big review article. It was published in the January 2024 issue of the Journal of Gastric Cancer.
Right, and this paper really dives deep into the front lines of minimally invasive surgery for stomach cancer. It's not just a surface look.
Exactly. So our mission today is to unpack what's happening with reduced port gastrectomy, or RPG.
Yeah, we want to look at what RPG actually is, the different ways it's done, how it stacks up against the more conventional methods, and really importantly, why this matters to you, whether you're looking at this as a patient or maybe a healthcare professional, or maybe you're just fascinated by where medicine is heading.
Okay, so get ready. We're going to break down some key findings from this review, and we'll spend some time looking closely at the different types of RPG. Plus, we'll unpack the data that's summarized in the figures and tables in the article. Some really interesting stuff in there.
Definitely. Okay, so maybe we should start with a bit of history, just to set the
Oh,
stage.
good idea.
How did we get here?
Well, for a long time, if you needed a gastrectomy for gastric cancer, the only real option was a big open surgery. Very invasive, long recovery. But then, a big shift happened back in 1994. Kitano and his team introduced laparoscopic distal gastrectomy.
So using cameras and small instruments, that was the start of minimally invasive.
Exactly, it was a real game changer. And it led pretty quickly to minimally invasive techniques becoming much more common. Right. And the standard that emerged was often this 5-port system, what we now call conventional laparoscopic gastrectomy, or CLG.
That's right, 5 small incisions. But, the innovation didn't just stop there. People kept pushing. Techniques like totally laparoscopic gastrectomy, or TLG, came along.
And TLG means everything's done inside, even the reconnection.
Precisely. No need for a larger incision to bring things out and reconnect them. It's all done laparoscopically. It just shows that constant drive.
Yeah.
Less invasive.
Which brings us neatly to reduced port gastrectomy, RPG. This is the next step on that path.
It really is. It's the next frontier, you could say, in minimizing how invasive the surgery is. The whole idea behind RPG is simple. Drastically cut down the number of ports, those little incisions.
Fewer ports means fewer scars.
Fewer scars, and hopefully potentially a faster recovery for the patient. That's the goal.
So if we're talking minimal invasiveness, what's seen as the ultimate version of this reduced port idea?
Good question. The technique often highlighted as the ultimate, especially for cosmetic reasons, is single incision laparoscopic gastrectomy, CLG.
A single incision, just one.
That's the idea. All the instruments, the camera, everything goes through one small cut, often right at the navel, so the scar is hidden.
Wow, that sounds fantastic for the patient cosmetically, but I imagine that's incredibly difficult for the surgeon, operating through one tiny spot.
You've hit on a really key point there. Pure CLG sounds ideal, right? But it brings some serious technical headaches. And this is where Figure 1 in the review article is super helpful. It shows how things evolved because of these difficulties.
Okay, let's look at Figure 1 then. How does it lay out this evolution?
So Figure 1 starts with what it calls pure CLG. Like you said, all the tools go through that single entry point, maybe using a special multi-channel port. But imagine trying to work with several inks all coming from the same angle. In a tiny space, they're constantly bumping into each other, getting tangled up.
Yeah, I can picture that, like trying to knit through a keyhole.
Exactly. It makes precise movements really, really challenging.
So how did surgeons adapt? What variations does Figure 1 show?
Well, faced with those collisions, they got creative. The figure shows the next step, for instance, needle grasper assisted SIL or SIL plus A.
CLG plus A. What's the A?
The A is for assisted. They add a very thin, almost needle-like grasper through a tiny separate puncture. It's barely visible. It just gives them that little bit of extra help, maybe to the tissue or provide some countertraction without needing a full extra port. Still mostly single incision, but with a tiny bit of help.
Okay, like a minimalist assistant. And then Figure 1 shows things moving towards slightly more ports, but still fewer than the old 5-port way.
Precisely. The figure then illustrates 2-port laparoscopic gastrectomy, 2PLG, and 3-port laparoscopic gastrectomy, 3PLG. Here, surgeons use, well, 2 or 3 standard trocars, those little tubes. Sometimes they might use one multi-channel port plus 1 or 2 regular trocars.
But still significantly fewer than the 5 in conventional CLG.
Right. It's all about finding that balance
Yeah.
between getting the best cosmetic result and maintaining good surgical control and visibility.
And the review article uses a specific term for these ones that aren't pure single incision. Reduced multiport gastrectomy, RMPG. Can you break that down?
Yeah, that's a useful distinction the paper makes. RMPG basically groups together all the reduced port techniques except pure SILG. So it includes 2PLG, 3PLG, and that SILG plus of what we just talked about. It highlights that, yes, we're reducing ports compared to conventional, but we're still using multiple ports, just fewer of them. It's a more accurate description for that category.
Got it. And the paper also mentions duet or solo surgery. What's that about?
Ah, right. Those terms duet or solo, they actually refer to the number of surgeons working, not the number of ports. For example, a duet surgery might often be done using a 3PLG setup, because with fewer ports, maybe you don't need a dedicated assistant holding a camera or retracting. But it's about the team size, not the incisions themselves.
Okay, that clarifies things. So fewer ports, better cosmetics, sounds great. But you mentioned technical headaches. Let's dig into those challenges surgeons face with RPG.
Absolutely. It's not all smooth sailing. In pure CLG, that issue of instruments colliding in a tight space is constant. Makes fine dissection tricky.
Like instrument fencing?
Kind of, yeah.
Yeah.
And there's another specific risk with CLG, especially when entering through the navel, potential pressure on organs like the pancreas during certain movements. You have to be very careful.
And what about generally across all RPG types? Is there a common challenge?
I'd say the biggest one, generally, is achieving good traction and countertraction.
Okay, explain that.
So in surgery, you need to gently pull tissues in opposing directions to open up spaces, expose the structures you need to see and work on. It creates your surgical view. With fewer entry points, it's just physically harder to get those opposing forces applied effectively. Makes visualization and dissection more challenging.
Right. So how do surgeons actually overcome these hurdles? What tricks or tools do they use?
Well, the paper points out some clever solutions. Surgeons might use specially designed instruments, like graspers that are curved or instruments of different length, specifically to avoid those collisions.
Ah, smart.
They can also use the operating table itself, tilting the patient. So gravity helps move organs out of the way. And for that crucial traction, countertraction, they bring in those extra little helpings we mentioned, like the needle graspers or specific organ retractors designed for minimally invasive work. It requires a different skill set, definitely.
And like any new skill, there's a learning curve, right? How long does it take to get good at RPG?
There absolutely is. The studies mentioned suggest that for CLG, for example, surgeons probably need to do around 30, maybe 33 cases to feel really proficient.
That's quite a few.
It is. But what's encouraging is that the research also shows RPG is feasible and safe, even when introduced in smaller hospitals, not just major centers. It suggests that, with the right training and a careful approach during that learning phase, surgeons could adopt it safely.
And being careful means?
It means choosing patients carefully initially, maybe starting with less complex cases. And critically, always being ready to add another port or even convert to conventional laparoscopy or open surgery if safety becomes a concern at any point. Patient safety has to come first, always.
Absolutely. Which brings us to the big questions. Is RPG safe overall? And does it work as well as conventional surgery for treating the cancer? Let's dive into the data the review presents.
Okay. The article does a great job summarizing studies comparing RPG with CLG. Let's start with distal gastrectomy, removing the lower part of the stomach. Table 1 in the review focuses on comparing SILG, single incision, versus CLG, based on retrospective studies looking back at past cases.
And what did those retrospective studies find? Any red flags for SILG?
Actually, quite the opposite, reassuringly. Across the different studies summarized in Table 1, there was no significant difference in things like patient BMI, the rate of complications after surgery, morbidity, mortality rates, or how long patients stayed in the hospital.
So on those big safety markers, SILG looks comparable to the standard CLG.
Exactly. That's a really important baseline finding. No major new risks popping up with the single incision approach in these areas.
Okay, that's good news. What about the surgical details? Anything stand out in Table 1? I think you mentioned blood loss earlier.
Yes. This was a consistent positive finding for SILG in Table 1. Estimated blood loss was significantly lower in the CLG groups across all the studies reviewed.
Lower blood loss, that's definitely a win for the patient.
Absolutely. Less blood loss can mean fewer transfusions, maybe a slightly easier immediate recovery. Operation time was a bit variable in the earlier studies, sometimes longer, sometimes similar. But interestingly, some newer reports are suggesting Silgi might even be shorter now, perhaps as surgeons get past the learning curve.
And the crucial part for cancer surgery, getting the cancer out properly, what about the oncological outcomes like lymph nodes?
Also very reassuring. The number of lymph nodes removed, which is key for staging the cancer and ensuring a thorough removal, was comparable between Silgi and CLG groups in Table 1. And while only one study in that table looked at long-term survival, 5 years, it found no significant difference either. It was around 95.8% for Silg versus 94.2% for CLG, so oncologically it looked solid.
Okay, that's SILG. Now, Table 2 broadens the view to other types of RPG, the reduced multi-port gastrectomy, RMPG approaches. So 2-port, 3-port, or SILG with that needle assist. How do they compare to CLG for distal gastrectomy?
Pretty similar story, actually. Looking at Table 2, operation time was again inconsistent, sometimes shorter for RMPG, sometimes longer, particularly for the 2-port technique in some studies. Estimated blood loss was either no different or, again, sometimes lower in the RMPG groups. Another good sign.
And lymph nodes, still comparable.
Yes. Lymph node counts were either similar or even reported as slightly greater in the RMPG groups in some studies. So again, no compromise seen on the cancer removal aspect. And just like SEAL, Table 2 showed no significant differences in length of hospital stay, complication rates, or mortality for RMPG compared to CLG. Plus, 2 studies in Table 2 looked at survival out to 3 years and found no significant difference in overall survival or the chance of the cancer coming back.
So, taking Tables 1 and 2 together, the message from these retrospective studies seems pretty clear for distal gastrectomy.
All right. Based on looking back at all these cases, the conclusion from the review is that RPG, whether it's LG or RMPG, is generally considered safe and likely as effective, maybe even with some advantages like less blood loss, compared to conventional laparoscopic surgery for distal gastrectomy.
That sounds like a strong endorsement based on past experience. But you always hear that prospective studies, especially randomized controlled trials, RTTs, are the gold standard for evidence. What do they show?
That's the critical next question, and the article addresses it using Table 3. Table 3 focuses specifically on the prospective RCTs comparing RPG and CLG for distal gastrectomy.
And are there many of these RCTs?
Well, that's the first point. Table 3 shows us that the number and size of these high-level trials are still pretty limited. To date, there have only been 2 published reports on 2 PLG trials and 2 on CLG trials.
Okay, so limited data, but what's the general finding from these RCTs so far?
The overall picture is consistent with the retrospective data. Generally, no significant difference found between RPG and CLG in the main outcomes like complications or hospital stay. Again, reassuring for safety and basic effectiveness. Operation time, though. Still conflicting results, even within these RCTs.
Okay. What about those things that really matter to patients day to day, like pain after surgery or how the scars look? Are the RCT results clearer there?
That's where it gets a bit fuzzy. For post-operative pain and cosmetic satisfaction, Table 3 shows mixed results. Some RCTs did find patients reported less pain or were happier with the cosmetic outcome with RPG, which kind of makes intuitive sense. Fewer holes, less pain, smaller scars.
But not all of them.
Right. Other RCTs found no significant difference. And this really highlights how tricky it is to measure subjective things like pain or satisfaction objectively in a trial setting. You can't exactly hide from a patient how many scars they have.
True. It's hard to blind that aspect.
Exactly. So while the trend might lean towards better pain and cosmetic results, the high-level evidence isn't definitive yet. That's why the authors really emphasize the importance of the ongoing KLA-SS12 study. It's a big multi-center trial happening in Korea, and everyone's looking to that to provide much more solid answers on these finer points. Okay, so for distal gastrectomy, RPG looks safe and oncologically sound, with potential benefits, but we're waiting on bigger trials like KLA-SS12 for final confirmation on some aspects. Now, what about total gastrectomy, removing the entire stomach? That's a bigger operation. It is definitely a more complex procedure. And Table 4 in the review summarizes the comparative studies for RPG versus CLG in total gastrectomy.
What's the first thing to note about Table 4?
Well, first off, all the studies included in Table 4 are retrospective. There are no prospective RCTs published yet for RPG in total gastrectomy. And the number of patients in these studies is generally smaller than for distal gastrectomy.
So the evidence base is less robust here. What did these retrospective studies find? Similar patterns to distal?
In many ways, yes. They generally found no significant differences in estimated blood loss, length of hospital stay, overall complication rates, or mortality between RPG and CLG for total gastrectomy. Operation times were either similar or sometimes longer for
I
RPG.
sense a but coming.
Yes. There is a critical finding highlighted from one study in Table 4 by Kim and colleagues. They reported a significantly higher rate of complications specifically related to the anastomosis, the reconnection in their RPG group for total gastrectomy.
Ah, reconnecting the esophagus to the intestine after removing the stomach, that's the tricky part.
It's one of the most technically demanding parts, yes. And the authors attributed this higher complication rate in the RPG group to the learning curve effect. It just takes time and experience to master that complex reconstruction through fewer ports.
So the takeaway for total gastrectomy using RPG is proceed with caution.
I think that's fair. The review suggests that while RPG for total gastrectomy shows promise and seems feasible in experienced hands, the lack of prospective data and that specific finding about anastomosis complications means surgeons need to be particularly mindful of the technical demands and the learning curve. Patient selection and surgeon experience are probably even more critical here than for distal gastrectomy.
Okay, that makes sense. Let's step back and summarize the key insights across the board. First, safety. Overall verdict.
Overall, RPT is considered safe. Most studies don't show higher complication or mortality rates compared to CLG, and that lower estimated blood loss seen in many RPG studies is a definite plus. But the caveat remains for total gastrectomy, specifically regarding the anastomosis during the learning curve phase. That needs careful attention.
Got it. Now, the really crucial point, oncological validity. Does RPG get the cancer out just as well?
This is where the news is consistently good, and it's fascinating, really. Despite few reports, the studies consistently show no difference in the number of lymph nodes surgeons are able to remove with RPG compared to CLG. That applies to both distal and total gastrectomy.
So the thoroughness of the cancer removal isn't compromised.
Exactly. And even more importantly, the largest study looking at this by Lee et al. And several meta-analyses pooling data together all show no significant difference in long-term survival, looking at 5-year overall survival and disease-free survival.
Wow. So the bottom line is?
The bottom line, based on current evidence, is that RPG, including the single-incision CLO, is considered oncologically as good as conventional laparoscopic gastrectomy. That's a hugely important message for patients considering their options.
As good as, but potentially less invasive. Okay, let's revisit those potential advantages again. What's the real story on, say, length of hospital stay, LOS? Is it truly shorter with RPG?
Well, it's interesting. Lots of the retrospective studies did report shorter hospital stays for RPG patients.
But the prospective trials were less clear.
Exactly. The prospective data doesn't show such a consistent difference. So what does this all mean? It suggests that maybe other things are influencing hospital stay, like changes in general post-op care, maybe faster recovery protocols being used for everyone now, not just the surgical technique itself.
So the jury's still out a bit on LOS as a definite advantage solely due to RPG.
Yeah, we probably need those larger trials like KLAS 12 to really nail that down.
Okay. What about cosmetic outcomes? That seems like a pretty clear win for OPG.
Intuitively, yes. Fewer scars, smaller scars. It makes perfect sense that patients would be happier cosmetically. And studies have reported significantly higher cosmetic satisfaction with RPG. But the review does point out that this aspect, while really important to patients, sometimes gets overlooked or isn't measured rigorously in surgical studies. There's a need for more objective data here too, even if the benefit seems obvious.
And reduced postoperative pain. Is that a definite advantage?
Again, the evidence is a bit mixed, much like the prospective data on LOS. Some studies show less pain, which you'd expect, but others find no significant difference. Pain is just so subjective and hard to measure consistently study to study.
Right. And lastly, this idea of reduced surgical personnel. Duet surgery needing fewer assistants.
Yeah, the concept of duet surgery, maybe using a 3-port setup where the main surgeon can manage most things without a dedicated assistant, could be an advantage, especially if staffing is tight. But the review makes a really important cautionary point. Reducing staff shouldn't be the primary driver for choosing RPG. The decision has to be based on surgeon expertise, patient suitability, and above all, safety.
Okay, looking forward then. RPG seems promising, but clearly more research is needed. You mentioned KLAS 12 again.
Absolutely. That KLAS 12 trial and other future studies are going to be crucial. They'll help clarify these remaining questions about pain, LOS, and really pinpoint which patients benefit most from which specific RPG approach, tailoring the surgery to the patient.
And are there other potential benefits of RPG that maybe haven't been fully explored yet?
Well, if we connect this to the bigger picture, researchers are starting to wonder about other more subtle advantages. For instance, Could the even greater reduction in surgical trauma with RPG lead to, say, a lower inflammatory response in the body compared to CLG?
And why would that matter?
A lower inflammatory response might translate into other subtle recovery benefits, or maybe identify new groups of patients, perhaps those who are more frail, who might particularly benefit from the ultra-minimally invasive approach. It's about looking beyond just scars and pain.
And technology must play a huge role in enabling RPG and making it better.
Oh, definitely. There's a constant need for better tools designed specifically for RPG. Things like improved multi-channel ports that reduce instrument clashes, more refined needle graspers, better ways to retract organs gently, instruments that can articulate or bend inside the body.
Like tiny robotic arms, almost.
Sort of. And specialized scope holders to give a steady view. It really takes collaboration between surgeons and engineers to keep pushing the technology forward.
And speaking of technology, we can't ignore robotics. How does robotic surgery fit into the RPG picture?
Robotics is a massive part of the future here. You have platforms like the Da Vinci SP system. SP stands for single port, which is literally designed for single incision surgery.
So perfectly suited for SALG.
Exactly. Robots offer things like enhanced 3D vision, incredible precision, tremor filtering, and instruments with more dexterity than standard laparoscopic tools. This can help overcome some of those technical challenges of working in tight spaces with RPG.
Are there hurdles to robotic RPG?
Well, the source mentions current limitations, like cost and reimbursement issues in some healthcare systems, like Korea. But the expectation is clear. Robotic platforms will likely play an increasingly active role in RPG in the future, further refining these techniques. It's a powerful combination.
Okay, so let's wrap up this deep dive. The core message seems to be that reduced port gastrectomy is a really significant evolution in minimally invasive stomach cancer surgery.
Yeah, it offers clear benefits like less surgical trauma, great cosmetic results, and definitely the potential for faster recovery, maybe less pain, maybe shorter hospital stays. Some of that needs more confirmation.
And critically, as we saw from the data in those tables and figures from the review,
Critically, RPG is considered safe. And most importantly for cancer surgery, it appears to be oncologically equivalent to conventional laparoscopy. Surgeons can get the cancer out just as effectively, but with less impact on the patient's body.
So as you've heard today, surgical innovation is this constant journey, always aiming for better, less burdensome ways to treat patients. What does this exploration of RPG make you think about? That careful balance, perhaps, between pushing the boundaries technologically and ensuring we always have solid evidence backing up patient safety and long-term cancer outcomes. It's something medicine grapples with constantly, and it really shapes how healthcare improves for all of us.